Great. Well, I'd like to warmly welcome all of you and thank you for taking part in today's session. Josh, if you can pull up the slides, is entitled the Oncotype DX or Oncotype Map Pan-Cancer Tissue Test. And we'll be talking about best practices for decalcifying bony samples and preparation for genomic profiling. And I think this is a case of whether you do NGS in your own laboratory or you send samples out. This is an important concept, particularly given some of the PARP inhibitor trial data from this summer that is resulting in increasing numbers of submissions of prostate samples to many of which are bony metastases to inform PARP inhibitor treatment decisions. Next. I'd like to first start by introducing my colleague, Josh Routh. Josh is a laboratory medical director and will be speaking today. He is leading our efforts in NGS and performs the Oncotype MAP NGS tumor tissue assay. Before working at Exact, Josh completed his fellowship in molecular genetic pathology at the University of New Mexico, and he served as the director of clinical pathology at Southern Arizona VA healthcare system. Josh is also a faculty member at the Department of Pathology at the University of Arizona. My name is Rick Baehner. I'm the Chief Medical Officer of Precision Oncology at Exact Sciences. I formerly worked with Genomic Health, and I am also a faculty member at the University of California, San Francisco. Next slide. Perhaps a brief word first about Exact Sciences. I think you'll know Exact Sciences from the Cologuard assay, which on the left side of this screen is an assay for screening patients at risk of colon cancer and can detect colon cancer and advanced adenoma. About a year and a half ago, Exact Sciences acquired Genomic Health that has the Oncotype DX recurrence score and GPS assays. So we're part of the Exact family. Some additional acquisitions by Exact Sciences, and we'll look forward to future sessions. There was the acquisition of Thrive, which is using NGS and proteomics to develop screening assays for patients at risk of developing cancer. And then on the right side of this figure in green, we are focusing right now on minimal residual disease and are working now with a technology called TARDIS in a laboratory at Cheyenne to be able to run that minimal residual disease assay. However, today we're talking about NGS and tissue-based panels. And with that respect, we have an Oncotype MAP pan-cancer tissue assay, which is 250 genes, and is why we're focused today on this discussion around appropriate decalcification. Next slide. Today we'll be talking about, first of all, I'll introduce the topic of just really the growing importance of genomic profiling, frankly, just how incredibly exciting it is, the changes in molecular biology and how they're impacting our practices as we serve surgical and medical oncologists. Josh will be talking then about special considerations for bony specimens, as well as briefly talking a bit about the Oncotype MAP pan-cancer tissue test. So first of all, the emergence of precision medicine has radically transformed oncology, and it's had an incredible impact also on pathology. Now, this foundation was essentially laid not too long ago. In 2006, the federal government, through the NIH, funded what you'll hear referred to as the TCGA, and that is the Cancer Genome Atlas. And its goal was to understand genomic alterations that underlie major cancers. Multiple groups, it was launched in 2006, participated in comprehensive and integrated analyses of next-generation sequencing results for over 20,000 tumors with matched normal samples. This was a huge effort. There were 33 cancer types that were surveyed. And what was exciting is there were many variants that were identified that associated with morphologies that we've known and diagnosed for many years. But thematically, there were also variants that were identified that were not unique to a single cancer type, but were noted across tumor types. And this led to really identification of new targets and biomarkers that are subclassifying cancers and really led to the development of better treatments. Next slide, please. Now, comprehensive genomic profiling with NGS is an assay really that allows us to preserve tissue, scant tissue. So it can be used with an excisional sample, but also with needle core biopsies, cell blocks, and liquid samples, including plasma, CSF, and other liquid samples. It allows for the simultaneous evaluation of many genes, and it does this by generating millions of short nucleic acid sequences in parallel. What is exciting about this technology is the precision with which it can identify the 4 variants, the 4 different types of alterations, what I never forget John Pfeiffer calling the 4 horsemen of the genomic apocalypse. That's how I remember them. First of all, there are base pair substitutions or single nucleotide variants like KRAS. There are insertions or deletions of small parts of genes called indels. They can be up to 70 base pairs in length, and an exon, EGFR exon 19 deletions are great examples of this. There are copy number alterations or CNVs. These can be either amplifications or deletions, and HER2 copy number gains is a great example of that. A little bit more complicated are translocations or structural variants. These can be either between chromosomes or within chromosomes. And NTRK is a great example of a new fusion that is critically important in a pan-cancer FDA label for NTRK inhibitors. Next slide, please. Now, we have been pathology has radically changed just in the span of my career, which is, around 20 years. Much like cardiology and radiology, we started off with H&E slides and some chemistry. Now we've moved on to IHC and FISH are standard in most laboratories. PCR enables us to quantify things that are very lowly expressed or very highly expressed, great precisions around single nucleotide variants, a little bit more difficult with fusions, for example, that have heterogeneity in terms of where the genes break. NGS, as we talked about, is incredibly powerful because in addition to those 4 different types of variants, it's also useful for surveying large parts of the genome to allow assessment of tumor mutation burden, which generally involves sequencing of about 1 million base pairs to be able to make that call, or MSI. Next slide, please. Now, this technology change has really had a profound way in how we view cancer, and really non-small cell lung cancer is the poster child for this. When I started training, all the surgeons wanted to know in med oncs were, is it small cell or non-small cell? But with the advent of molecular biology and the identification of EGFR variants in rapidly targeted therapies, we saw non-small cell lung cancer go from simply a morphologic diagnosis to a very complicated, also molecular diagnosis. And this is extended to PD-L1 testing by IHC and tumor mutation burden, as I just mentioned. Next slide. The question arises, well, so what? You can measure, hundreds of genes, but, what's the prevalence of clinically actionable somatic mutations? And many groups have looked at this, but I think Memorial did a great job recently in publishing their experience in over 10,000 cancers. And using their levels of evidence, what they identified is that 37% in their original manuscript had 1 or more individual activating or individual actionable mutations. And that is shown in the pie chart in the lower right-hand corner of this slide. And actionable mutations for an FDA-approved drug was reported in 18% of patients. They updated this work in 2020, and you can see that the number of individual actionable mutations actually increased. But if you look at a subset of solid tumors in the histogram in the middle, what you'll see on the y-axis are various solid tumor types. On the x-axis, the percent of patients. And you can see that the number of actionable variants ranges anywhere from 25 to over 50%. So many patients derive very significant information from these comprehensive genomic profiling results. Next slide, Josh. Now, the utilization, this is what's so exciting, is we went from measuring single markers, just it seems like yesterday, to hotspot panels in kind of the mid-2010 era. And hotspots, these are panels generally that are a collection of frequently mutated sites within a gene or a few genes that are either clinically actionable or provide prognostic or diagnostic information. With the acceleration of targeted therapies, however, there's a shift from hotspot panels to comprehensive genomic profiling. And comprehensive genomic profiling generally assesses multiple genes, it can be hundreds of genes, and frequently involves many more exons, including the hotspots, but many more exons. And in the case of assays that use DNA to assess for fusions, introns also. Next slide, please. Now, this has led to just an explosion in terms of the correlation between markers we need to measure as pathologists and therapeutics that our clinicians want to give. CAP has done a great job and created guidelines on this slide for lung cancer, on the following slide in colorectal cancer. The lung cancer guidelines were initially written in 2013. They were updated, I think, in 2018. But this pace, there is not a month that goes by that there is not a New England Journal manuscript highlighting a variant with a new therapy, or a new tumor type with a known variant and a known therapeutic. If we look at the next slide, this just highlights the CAP guidelines for colorectal cancer. And again, certainly not the same plethora of variants that we're looking for in lung cancer, but what you'll notice thematically is tumor by tumor, we're seeing kind of growth in terms of the number of variants for which targeted therapies have been studied and have been shown to demonstrate a benefit. Next slide. Now, I think perhaps the most comprehensive guidelines are the NCCN cancer guidelines. They're available free online. If you haven't seen them, you should look at them. In addition to having multidisciplinary groups of physicians that sit on each of these individual tumor types, like non-small cell lung cancer, they also meet many times throughout the year and make recommendations. And within the NCCN guidelines, there's a short section that talks about variants and how to assess them that can be very, very useful. What I'd like to show you on this slide, though, is that for non-small cell, it's actually recommended the use of NGS. And you can see across these other solid tumors, it is now an option to be considered, or that it could be acceptable. So with the NCCN guidelines, oftentimes comes reimbursement, which is so critical to us being able to serve our patients. Next slide, please. Now, I think the most exciting area to date has been prostate, and that was due to the summer when there are some results that I'll show you in the next couple of slides before I turn it over to Josh. There was studies of HRR genes, or homologous recombination genes. And this positive trial led the NCCN guidelines and FDA label to now recommend tumor testing for somatic homologous recombination gene mutations to be recommended for all patients with metastatic castrate-resistant prostate cancer. And they even recommend considering testing for these markers in patients who have N1 or node-positive disease. Let's look on the next slide, though, at those results. Now, this trial was called the PROfound trial. And this is very relevant to our conversation around decalcification because, as you know, metastatic cancer prostate cancer frequently goes to bone. And in the PROfound trial published in the New England Journal of Medicine this year by De Bono et al., what they identified, first of all, in their primary analysis, they looked at almost 400 patients who had variants, mutations in HRR genes. Those are associated with homologous recombination repair. And the primary endpoint looked at BRCA1, BRCA2, and ATM. And what they found is patients who received olaparib, as you can see here in the blue curve, had a better progression-free survival, and not shown on this slide is an overall survival when compared to patients who did not receive that targeted PARP therapy. The slide on the right highlights, they then did a combined analysis, the secondary objective, looking at those top 3 HRR variants, BRCA1, 2, and 3, with the rest of the 14 genes that are associated with double-strand DNA repair. And again, what they found was a preservation of this effect, a treatment benefit observed in patients that had those variants. The next slide highlights gene by gene. You can see the histogram, increasing frequency up to BRCA2, which was the most commonly mutated gene in prostate cancer. You can see in the blue line patients who received the targeted PARP inhibitor versus in red the patients who received placebo. And you can see the magnitude of treatment benefit. And this evidence led to the recent FDA approval of olaparib for HRR mutated metastatic castrate-resistant prostate carcinoma. And this supports now broad genomic profiling for these variants in patients who have N1 or regional disease, as well as metastatic castrate-resistant prostate cancer. One more slide before I turn it over to Josh is there were a couple of manuscripts then highlighting the types of samples that were used in the PROfound study. There was a combination of both archival samples and newly collected metastases. They could be from the prostatectomy or needle core biopsies, but also important nodal metastases, visceral and bony metastases. So this highlights the importance. There are going to be many more requests for this type of testing in metastatic castrate-resistant prostate cancer. And I'll turn it over now to Josh to tell us a little bit more about how to appropriately handle those bony samples. Josh.
Thank you, Rick. That was an excellent overview of what has happened recently that contributes to genomic profiling being useful in patients with solid tumors. So Rick touched on this a little bit already, but NGS can be performed on a variety of specimens. It can be performed on primary tumors or metastatic disease. Oftentimes, patients who present with advanced cancer or metastatic disease, that's where NGS testing, such as the Oncotype map testing, is indicated. And a lot of times the only sample available is, or the only sample that can be easily accessed is going to be a bone metastasis. So a lot of times the only thing that's available to test is bone. Gene expression profiling requires nucleic acid though. It requires DNA and RNA that's high quality. So the decalcification protocol that your laboratories use is really important as far as making sure we get usable DNA, usable RNA for these tests. This table kind of highlights breast, prostate, thyroid, lung. These are tumor types that we have good actionable data for. And very commonly, as you can see here, that there are bone metastases in those diseases. So it's just another point highlighting how useful and how important it is to have a good decalcification protocol in place that not only looks at tissue processing, but also what are the effects on DNA and also some protein expression. So what is bone decalcification? Bone is a matrix of type 1 collagen that has been mineralized by calcium in the form of hydroxyapatite crystals. Decalcification is the process of removing that calcium that's binding it all together. And there are two main ways that this happens. One of them is with a strong acid. So figure on the left here is showing a strong acid coming in and dissolving the calcium here and some other chemical things happening. The other option is using a chelating agent such as EDTA. A chelating agent also dissolves calcium, but it doesn't form the same strength of bonds. It's a weaker bond and it has less effects on the DNA as well. So why is bone decalcification necessary? Decalcification is required for really any workflow that includes bone. You can't cut bone with a microtome, so the result of, as a result of that, you have to soften up the tissue in order to be able to cut it and process it through the normal workflows. Every good decalcification protocol follows a certain pathway. It starts out with formalin fixation as the first step. We really want to stabilize the proteins and the DNA, and formalin fixation cross-links those things and make sure we have good, stable tissue for the rest of the process. That's going to be followed up by decalcification, and there are a lot of factors that can play into that pathway. So quantification of the solution, so how concentrated is the solution. Also, we want to look at factors including the temperature, if it's being agitated, does the fluid have access to the tissue? And we want to test to ensure that the decalcification has happened as well. We don't know before we evaluate the tissue how much calcium there is, how strong those bonds are. And there can be a variable amount of time that goes into the process. So really testing for an endpoint is useful to make sure you're not over decalcifying and causing extra damage to the proteins and to the nucleic acids that are there. After decalcification, we process and embed the specimen as we normally would. So same tissue processor steps, same paraffin embedding, same cutting with a microtome, making slides, etc. All right, there are three main classes of decalcifying agents that we've already kind of talked about in the questions. So the first class is a strong mineral acid. Hydrochloric acid is the most commonly used, but nitric acid is also used, and the concentrations can get really high here, up to 10%. The advantages of these, and the reason that in traditional pathology workflows they're so prevalent, is that they're very rapid. The downside is that they do cause a loss of some nuclear staining, and they can damage tissue as well. They also have negative effects on DNA and RNA. The kind of intermediate region, or classification, are weak organic acids. Formic acid is the most common agent used in this category, and it's often combined with formalin. So you get some extra fixation along with the decalcification. So it's kind of a 2-in-1 step. The weak organic acids like formic acid they're slower than the strong acids, but they're also gentler and they're less likely to interfere with nuclear staining and also with DNA and RNA testing downstream. Chelating agents are the final category. EDTA is the most commonly used chelating agent in this category, and it can be up to 14% concentrations with a pH of around 7. It's a slow process, and it can take longer than the above workflows, but it is very gentle on the specimen. So there's less chance of over-decalcifying, less DNA damage, less RNA damage. It preserves high quality morphology and molecular elements. And we'll get into some data supporting that in a moment. So here's another table looking at common reagents in those categories. So on the top, we have strong acids, then we have weak acids and chelating agents. And we've talked about kind of the key elements inside there, but each mixture has some differences, some different, secret sauce added into the mix that either makes them better or faster or some combination. It's important when you're choosing one of these agents that you're considering how it affects the nucleic acid integrity, because as we've established, the NGS workflow is so important. Strong acids they degrade the nucleic acid and they can really inhibit the testing we can do downstream and ultimately hurt the patient or require rebiopsy. Okay, so here's a study looking at the NGS success rate and how it's impacted by bone decalcification. This is a retrospective review, kind of a lab experience paper that looked at a lot of data from a really excellent next-gen sequencing site. And they evaluated their cases to determine what was causing NGS failures, if there were any factors there that were leading to increased failure rates in some subcategory. So kind of a regression analysis looking at what led to NGS failure. The types of characteristics they looked at were the type of tumor, how large the tissue was, the age of the FFPE block, and then also some factors such as the size of the tumor that was in there and the whether or not bone decalcification had happened. They also looked at the site of the biopsy, not just the type of tumor that was there. So looking specifically at bone biopsies, there were a total of 19 that were evaluated in the study, and it had an NGS success rate of 63%. The table in the bottom right-hand side over here shows that overall, there's an 89% success rate. So a big drop-off in NGS success in those bony specimens. And one thing to note here is that they actually had an excellent in-house protocol for decalcifying those specimens. They used formic acid. They had a lot of control over that process. 2 of the specimens that were involved in the evaluation were using an outside institution's decalcification protocol. If you exclude those and look only at the ones using the in-house, the success rate was moderately higher. It was in the 70% range. So there is certainly a difference between bone samples and other samples for NGS, even when trying to control and doing a good job. In cases where there's no consideration for NGS testing, we can assume that the performance of NGS would be even worse in these cases. All right, looking at another study, this study looked at the decalcifying agent and the impact on the quantity and quality of DNA and RNA recovered from bone biopsies. This was an interesting study that looked at a variety of commercially available decal solutions, and the way it compared them was kind of a contrived study where they took core biopsies from amputation specimens and randomized those core biopsies to one of the below agents. Everything else in the workflow was the same. So first, the sample was fixed in formalin for 6 to 8 hours. Then it was rinsed and decalcified for 2 hours. Again, the only variable here is which agent was used to decalcify it. Looking at the agents they used here, some of them contain formic acid, Formical-4, Formical-2000, Immunocal, Surgipath decalcifier. Those are all formic acid containing reagents. And then 14% EDTA was also in that weak acid category. The other samples, the other agents that they used to decalcify were strong acids, mostly based on hydrochloric acid, and one of them, Nitrocal, used nitric acid. So here are the results of that study. Let's look at the tables on the bottom. The table on the left shows weak organic acids and strong organic acids, and the y-axis here is the mean DNA yield. There are gray bars and black bars. It may be hard to read if you're on your phone or on a laptop here, so I'll just tell you, the gray bars are DNA yield, and the black bars are DNA CT. To test the DNA integrity, they did a quantitative PCR, a qPCR assay. So when the black bars are lower, that's a lower CT value and better DNA integrity. So comparing the weak acids to the strong acids for DNA, obviously the weak acids perform better. You could argue that EDTA performed very well here. The only one that may have performed better was Formical-2000 that had higher DNA yields and also excellent CT values. The strong acids performed relatively poorly. The amount of DNA that was yielded, those gray bars, was significantly lower, and the CT values were significantly higher. Nitrocal performed better than the other ones, so if you are looking at a strong acid, Nitrocal may perform slightly better. Looking at RNA yields from the same study, there were, again, we had great performance on the weak acids, with EDTA performing the best in that class as far as RNA, both integrity and concentration. And for the strong acids, Nitrocal also performed best in that class. But if you look at the actual CT values for Nitrocal, for both DNA and RNA, you'll see a pretty big spike, especially in RNA, as far as the integrity, how usable that was for a qPCR assay. This slide is just looking at those results kind of aggregated together. And the takeaway here is that there is a statistically significant difference that's in favor of the weak acids compared to the strong acids for both yield and DNA integrity and RNA integrity. And that's true for all the measures there. EDTA performed very well as well as formic acid in this study. So both viable options according to this. Okay, so the next study looked at breast tumors, breast biopsies, and it was another contrived study where they took real patient samples and they took multiple sections out of each breast tumor. Each sample was split up and run through one of the following workflows. So the first workflow is the control workflow that didn't do any decalcification. The others were run through workflows that included decalcification in different ways. First, Formical-4 with microwave at 37 degrees Celsius. Next up was Christensen's buffer with microwave at 37 degrees Celsius. Then Christensen's buffer on a shaker at room temperature. And a shaker is just agitating there to give more access between the fluid and the tissue. And the last one was EDTA on a shaker at room temperature. Christensen's, I should note, is a formic acid containing solution. So that's another formic acid possible solution here. That was split up and run through multiple tests were performed on each block. IHC, so ER, PR, and HER2, which we're all familiar with. Fluorescent in situ hybridization FISH for HER2, and also DNA and RNA isolation. Let's look at the results of that. So let's start looking at the DNA and RNA quality. Here are some samples, some tables comparing each of those different. So first we're looking at DNA, and on the x-axis we have each protocol that was used to decalcify it. So the control is on the far left here, and EDTA is next. The y-axis is the 260-280 ratio, looking at absorbance of that, and really it's a measure of DNA purity or DNA quality is how they referenced it here. EDTA performs the best, looking at that RNA ratio. Same thing for DNA. EDTA performs very similarly if we're looking at just those average lines on there. And we have a drop, a lower 260 to 280 ratio, which is a worse performance on Christensen's buffer and Formical-4. Looking at the DNA average fragment length, this is a really important measure for next-gen sequencing testing because we need longer fragments to get those reads and to get usable data as far as mutations in a patient. So EDTA also performed the best here, looking at fragment length based on this study. Formical-4 performed very poorly. Fragment length was really in the gutter, 0 there. I wonder if there was an issue with some damage to the DNA from the Formical-4 that inhibited the assay even. But the Christensen's buffer with and without microwave also had shorter fragments there. And that's going to result in worse coverage, worse performance in the NGS test. All right, so again, to summarize, EDTA performed the best out of the 4 protocols, the 4 decalcifying agents that were considered in this study. The same study, so same test setup, looking at IHC stains. There was overall a decrease in IHC stain intensity for each of these markers and each of the protocols. But the conclusion of the study is that it wasn't a significant decrease. Most of the cases that were evaluated, the control and the test method had the same score overall. So it would be considered ER positive or PR positive as the control was considered positive, or negative if it was negative. The biggest risk that they identified was in HER2. There were some cases that crossed the HER2 threshold, where instead of a 3+, this one in the image here is scored as a 1+. And that is a pretty significant issue if we're looking at Christensen's with buffer. Even dropping from a 3+ to a 2+ with Christensen's buffer without microwave could have significant effects on the patient. So EDTA performed very well here as well. Looking at FISH in the same study, effectively EDTA is the only protocol where FISH can be interpreted at all. So Christensen's buffer with microwave and Formical-4, there was no definition. There were no actual dots that could be seen in the FISH. The cells couldn't be scored. So EDTA is really the only acceptable option processing for FISH in this study. Okay, this is an excerpt from a CAP Today article that looked at a few other small studies similar to the one we just discussed, specifically looking at ER, PR, and HER2 staining. I'm not going to get into the details of these studies here. There's too much data here to really process. But the takeaway from this CAP article is that these studies together, kind of considered in aggregate, show that ER, PR, and HER2 can still be performed on decalcified specimens. There is some negative effects, some shift from positive, down the spectrum toward negative. But for a majority of cases, there will be concordance, and it could be worth doing still. So it's better than not knowing the information as far as, perform the test, don't perform the test. I think CAP is pretty clear, though, about interpreting these results with caution. There are checklist items that those of you running histopathology labs are, I'm sure, very familiar with, about how if you haven't validated your stains, especially these ER/PR and HER2 predictive markers here, on decalcified specimens, then you're required to add kind of a comment on the report disclosing that and recommending that the provider interprets those with caution. All right, here's another study that's looking at the impact of decalcification on IHC and molecular testing on bone samples. Unlike those last two contrived studies, this one is more of a clinical look at real patient specimens. So specimens came in and were processed using different modalities, and the success rate of those modalities was compared. The element that this adds to the discussion we're having today is, instead of just looking at those agents, the decalcifying agents, they also looked at the impact of cycle length and the number of cycles. So the amount of time that the specimen was decalcified. For that, each of these agents, hydrochloric acid, formic acid, and EDTA, had different cycle length definitions in the study. First, hydrochloric acid had a 4-hour cycle, decalcification cycle. Next, EDTA had an 8-hour definition for one cycle. And then formic acid had 3 different cycles that were compared. Short cycles being 6 hours, overnight cycles being 12 hours, and long cycles being 24 hours. So let's hop forward to the results of the study so we can compare those cycles and the number of cycles and the effects. All right, so let's focus on this first chart here. This is looking at IHC intensity scores for those different agents, the different decalcifying agents. Hydrochloric acid had the lowest IHC intensity scores. Formic acid and EDTA performed better. And again, it's a low number here in the study, so I don't think EDTA enhances the IHC staining. I don't think that's what we're arguing here, but EDTA performs very similarly to no decalcification in this group of samples. Similarly, looking at the next part here, so in table A, we're looking at both DNA and RNA integrity. They combined into kind of a meta score. So they were looking at CT of IDH1, and that's again that's inversely correlated to the quality of the DNA that was extracted. So bottom right corner of that is the no decalcification. So there's our control. And EDTA is scoring really similarly to that control. So again, EDTA is performing well, looking at the integrity of the DNA. And looking at formic acid, another option for in the weak acid category, we have short, overnight, and long processing times, and we have increasing CT values. So as those cycles get longer, as there's more time that the specimen is decalcifying, we're seeing an increase in the CT value, so worse DNA integrity. Same thing looking at the number of cycles. So as the number of cycles increases for all of these different types of decalcifying agents, the DNA integrity is decreased. So the amount of time that a specimen spends decalcifying also has a negative impact on DNA integrity. So just to summarize so far what we've gone over, next-gen sequencing is an important tool that is growing in usefulness across a number of tumor types. It's used, Rick really outlined some of the uses for it there, but it is an important tool and a great thing to have in our tool belt as clinicians. Bone is a common site for metastasis, and we need to be able to process bone so that we can have successful next-gen sequencing tests and successful IHC tests as well. An optimal bone decalcification protocol is very important, and strong acids are not the most appropriate here. Strong acids are going to cause that damage to the specimen. EDTA and formic acid solutions have better outcomes. All right, studies have recommended EDTA as really the best performing decalcifying agent, and that's what we recommend for our laboratory. Both NGS and IHC testing of bone biopsies can be performed with the Oncotype map test for a comprehensive identification of actionable targets. All right, we're going to move on and talk about Oncotype map pan-cancer tissue testing now. So this is the test that we perform here at the Phoenix Exact Sciences Lab. It's a next-gen sequencing lab that also includes IHC stains to identify clinically relevant alterations. The goal of the test is to identify therapy targets. That's really what we're doing here. We're not trying to support a diagnosis. We're really trying to give the clinician the information they need to make the treatment decisions they need for their patients. The test includes 257 genes, 11 select fusions, 22 IHC stains, including PDL1, and that's 2 clones in there, 22C3 and SP142. There are 30 tumor-specific panels, so not every case is going to get all 22 IHCs. That would be a waste of tissue. We curate those panels based on the tumor type to make sure that each specimen, we're not wasting tissue, we're not overbilling the patient or the insurance, and we're still giving them the actionable data that they need. Our test reports copy number variants, tumor mutational burden, microsatellite instability based on the NGS data, and the protein expression is covered with the IHC panels that we do. Just a few things to note here as far as what are the advantages of this test. You know, there are a lot of tests out there in the market. And really, the two biggest advantages from my perspective is that the results are reported in 3 to 5 business days. That's huge compared to some other turnaround times out there. So really shortening the amount of time between when the clinician decides that they want this testing and when they have the results in the hand, that's our goal here. That's what we're trying to crunch down. The test, another thing that's great about it from a pathology perspective is that we accept FFPE samples as small as 3 millimeters squared with as little as 15% tumor content. This next slide just kind of shows 2 of those things compared to our competitor, our unnamed competitor that's out there in the world. 3 to 5 business days, I think industry standard is about 14 days, so calendar days, different measure there. And the minimum specimen requirement, 3 millimeters squared compared to 20 millimeters squared to 25 millimeters squared. And if that number is confusing, we're talking about the cross-sectional area of all the tissue there, not just the tumor. So if you have 3 millimeters squared, which is about the size of a grain of rice, and there's 15% tumor in there, we can accept that and perform testing. And our failure rate is low, it's 8%. So our success rate, another way to look at that, is 92%. So that's really the advantage that we have here, and hopefully a plus we can add to people's laboratories and workflows. We have some excellent specimen submission guidelines that have been put together that talk about evaluating your case to find the best block and preparing the tissue to send to us as well. One thing I'll point out here is that tissue blocks are greatly preferred. If we're looking at our success rates, tissue block versus slides, we are more likely to be successful if we have the tissue block because we're able to troubleshoot things more easily. If we get slides, we can do it with a very small number of slides. However, when things go wrong, it's great to have that block there just in case. The other thing to note is that this sample submission guide is available as a PDF on our website. If you just Google specimen submission guidelines Oncotype map, that'll bring you there. Bone decalcification, we also have a guide that you can use to help develop your own in-lab decalcifying procedure with recommendations here. And it's really these recommendations are backing up what we've gone over in the talk today. So things highlighted in bold here. So that optimal pH is between 7 and 7.4. The decal time and the quantity of solution used is really important there. Making sure that we're not using too much acid and making sure that we completely fix before we decalcify it is very important. All right, just to summarize again what we've gone over, personalized medicine is a growing field. It's rapidly expanding. We're getting new biomarkers discovered, new targeted agents are coming through every day. Those NCCN guidelines are being updated all the time. It's an exciting time to be in personalized medicine, to be in pathology, for sure. Next-gen sequencing is really the only way to move forward when there's so many biomarkers that you need to screen a case for. Looking individual tests for biomarkers, we're going to run out of tissue, especially in these critically ill patients where all we have is one biopsy NGS can get the answers without using up tissue or making the patient go back for rebiopsy. Bone biopsies frequently come up, and we need to make sure that they're processed appropriately so that we can do downstream testing and get the patients the best answers that we can. All right, an Oncotype MAP pan-cancer tissue test offers a comprehensive panel for NGS and IHC testing, and we do accept decalcified specimens in that. Okay, I'd like to open it up for questions now. Thank you all for your time here. I think we have about 10 minutes left for questions.
Great. And then Josh, I think just wanted to let everyone know that you're going to need to exit the full screen mode in order to ask questions. So you've kind of got to get out of that full screen mode if you want to type in a question. That being said, Josh, we've gotten a couple of questions.
Okay.
Certainly, I think many people share the enthusiasm for NGS. I think a lot of people, this is why they've gone into pathology, is how exciting molecular biology is. Thanks for this conversation on decalcification, which continues to be an Achilles heel. It was challenging in IHC, remains challenging, and to your point around the read length fragment, continues to be problematic if you destroy DNA. That one question that came up though, and just said, can you summarize kind of what's the best decalcifying agent to use? And maybe we'll start with that question.
Sure.
From your data. From the
data, EDTA, if you look across all the samples, all the things that we looked at today, EDTA performs as well or better than the other agents. So something that contains EDTA at a neutral pH at that 7.0 to 7.4 is your best bet to get useful data for your patients out of the sample. Great question.
Great, Josh. There's another question in terms of the platform that is deployed that you're using for NGS testing. And can you comment at a high level how you can use such small input?
Oh, absolutely, yeah. So the test that we use is really designed kind of more like a liquid biopsy test, where we use UMIs, unique molecular identifiers that are tagged onto each specimen. And that happens early. That's before we've done any processing on the DNA. And that allows us to track that particular molecule all the way through the process and gives us more certainty about what's happening with that molecule. So it allows us to have higher sensitivity throughout the process and allows us to really amplify up, get more answers out of a small sample. So I'd say that the UMIs and really designing the whole test around small sample size is the way that we achieve that.
Great. And what next generation sequencing platform are you using? Illumina?
Oh, yeah. Illumina. We're sequencing on Illumina. Yeah.
Super. Got just a couple of more questions and then we'll let people go, as I know they need a little bit of time between meetings. But the other question was, what can I do if I don't have access to EDTA?
Yeah, so if you don't have access to EDTA, we went over a couple of other agents that are available. I'm just going to go back to what those were here. So Versinate is one, and OsteoSoft is another that you may be able to find through a regular provider of laboratory reagents.
Super. There was one other clarifying question regarding the smallest amount of tissue. So obviously you've asked people to select the longest linear length of the most representative tumor, but when you have a small sample, what are the parameters in terms of how small that size can be?
Yeah, absolutely. So with small samples, and I think bone biopsies are often very small. Other core biopsies can be small, especially after you've done your workflow, your workup. There's not a lot of tissue left. So all we need is 3 millimeters squared of tissue in the cross-sectional area. However, if there is another block that has more tissue available, we would obviously prefer that. We are able to do macrodissection as well. So if you can't get to that 15% mark for tumor cellularity, but you have a block that has a large chunk of tumor on there, we can take that area and only extract DNA from that area to get us more accurate answers too. So that's another way we can help with samples that don't meet other requirements.
And then Josh, it looks like the final question that we're getting is, you showed us the 90% turnaround time, but can you tell us what the typical turnaround time is for samples that are submitted for the Oncotype MAP pan-cancer tissue test?
Yeah, absolutely. I track that really closely as the medical director. I every week review and samples that are over our turnaround times. I'm looking into why that happened. 4 days is the average turnaround time, 4 business days. So that if you interpreted that over the calendar days would be about 6 calendar days. That is the average turnaround time.
Well, super. Well, Josh, thank you very much. Also want to thank USCAP for hosting this, and want to thank all the participants for joining in today. This is a super exciting time in NGS, and look forward to talking to you soon in person. Thank you. Thank you, everyone.